Okay, hello everyone. Happy Monday. Welcome to another VMR and another Alec and Austin session. So thanks for joining. Excited for the all internal affair today. Um, I'll just pass it to Alec to say hello and then we'll go from there.
Hi, everyone. Thanks for being here today. Looking forward to the discussion. Yeah, I'm just on service, so have a lot of great cases that hopefully one day I'll be able to share. But big shout out to Magnus, who's going to be doing the scribing, and Sarah, who's going to be doing the teaching points. And we have Himun to present another case of the many she has presented recently. So if you three just want to say hello, and perhaps we can get the whiteboard shared and get started.
Yeah, so it's my honor to present this case to my amazing mentor, Austin and Alec. Yeah, this will be fun. So let's start it. All right, so a chip complaint, I will start first. Just a moment. Chip complaint is severe and progressive left upper quadrant pain radiating to the back. I will stop here.
Okay, I think Alex started first last time, so I will try to take a stab at this here. So we have, a few different identifying features here. So we have something to localize us to the abdomen, in particular the left upper quadrant. We have severe, and then we also have a progressive. So I think there's a lot to untangle in all of that. I have to just say, like, already doing an autopsy on my cognitive autopsy on myself, like, I'd already sort of translated this to sort of like a hyperacute syndrome, which is wrong because it's sort of implied by the progression that there's at least some amount of time that this was going on for. But I think the trap that I have got myself into is the idea of it being severe. And severe, I think, for me as a cognitive error says like, oh, if it's severe, it must be something terribly morbid. But unfortunately, in real life, the severity of how someone presents pain-wise doesn't necessarily reflect the severity of pathology. So I'm happy to say that I caught myself doing that. So we'll try to make progress. So I think at this point, I'll probably think through the idea of the left upper quadrant crane and the radiation to the back, and then kind of I'll have Alec layer in the sort of severe and progressive aspect. So I think like most people, whenever I hear about abdominal pain or flank pain, I sort of think of anatomical approach of like what is in that particular area, and sort of use the uh, arrow analogy that Reza had taught. At least that's who I remember learning it from. Where just imagine that if you whatever area that's hurting, you shot an arrow through it and what layers pass through, and that can give you a rough differential diagnosis of what's going on. So I think I'll be running through that list. The fact that it radiates to the back, I think, is actually really interesting because it implies the idea that there's referred pain going on. And whenever you think of referred pain to the back, usually it implies there's some sort of diaphragmatic irritation. So I'm already thinking of the structure. Well, we'll see. Excuse me. I should say, since it's the upper quadrant, I'm sort of translating it to diaphragmatic, but we'll get some more information about like where in the back the patient's experiencing pain. But I think the idea that this could be a peridiaphragmatic structure, especially since the pain is in the left upper quadrant, is possible, but also sort of the deeper retroperitoneal structures would also be at play. But yeah, I like I sort of rambled along and not anything said anything too specific. I wonder what thoughts do you have?
No, thanks, Austin, for your reflections. And I think, yeah, leftover quadrant pain, I think I shared the same sort of anatomic approach. But the relation to the back, I agree, is interesting and suggests something either in the retroperitoneum or irritating something around the diaphragm or in the retroperitoneum. And so there's lots of things that live in that area. So the spleen being one to think about, the stomach, the sort of the tail of the pancreas. There's obviously intestines that are there. And then, depending on where exactly in the left upper quadrant, I feel like patients often sort of point to that area, but then the pain is maybe more posterior. So you can think about, the kidney or aorta or other things. So it is very, it's nice to have some place to start and then sort of building off from there. And so I guess I'd love to know what features this left upper quadrant pain um, also brings with it. Because I feel like isolated left upper quadrant pain, I don't know if I can really think about a time where I had left upper quadrant pain and like nothing else besides maybe like zoster on the skin, right? Most people are going to have something else like early satiety or um, you know postprandial abdominal pain, or they're going to have diarrhea, or they might have dysuria, or they might have fever, right? So I think it's going to be interesting to see what company it keeps. And the severe progressive just says, yeah, it's this has been going on for at least probably acute to subacutely. And the severity either says that it's been a sort of more slowly progressive syndrome, or there's an acute worsening of a more subacute to chronic syndrome. And I think everybody's definition of severe is a little bit different, and people, access care at certain times for multiple different reasons. So the qualifiers are important to sort of stress if the patient has severe pain. We definitely need to figure out what it is, and do some more quickly. But I think otherwise it's a little harder to make progress. Besides knowing that, okay, the left upper quadrant is there, figuring out the associated features, and then an anatomic approach from there, plus the exam will be helpful. And then we can talk later on about how, when the pain localized to the left upper quadrant as well, like also not thinking of, forgetting about pathologies above the diaphragm, right? So particularly in the lung or the pleura would be something else not to miss. Um, but in my brain as well as a hospitalist, just thinking about if this is truly what the syndrome is, it's going to be hard for me to make further diagnostic progress likely without pictures. But I want to be a good clinician and try to think about what's going to be the best test moving forward. But yeah, Hemoon, I would love to hear more.
Yes, amazing discussion. Yeah, I think HPI, I think I can answer some of your questions. So let's just start with HPI. Okay, so HPI, a 37-year-old female with a no significant past medical history, present with a 1 week of severe progressive left upper quadrant pain radiating to the back, worsened by deep breathing and meals. She reported nausea, vomiting, and early satiety. She had a transition a loose stool but denied jaundice, constipation, urinary symptom, or hematuria. She reports no trauma, no animal exposure, no travel, and no recent medication use. And also no family member have a similar symptom either. I will stop here.
Okay. And then sorry if I missed it, Hemoon, but any fevers or chills at all?
Yeah, there was fevers, like mild fevers and chills. Not
Okay.
like rigor, but yeah.
Okay. No, thank you so much.
Uh-huh.
So yeah, so I guess I can take a stab at this for now. So if that's where you wanted us to stop, Hemoon. Uh, Yeah. Okay, great. So, yeah, so I think now we get a little bit more of the patient background and the sort of temporal history of the patient. So 37, quite young. No significant past medical history, at least that we're aware of, but so just because a patient says they don't have any past medical history, whether from excessive care issues or difficulties with memory or, otherwise, doesn't mean they don't actually have any past medical history. So just keeping that in mind. But we get a syndrome of what I would describe as sort of luminal symptoms of nausea, vomiting, early satiety, some loose stools on a background of inflammation, and the syndrome seems to be acute. That has only been going on for 1 week and has been very significantly progressive. And then Hemoon gives us the qualifier that it's worse with deep breaths. So there's a pleuritic component to this. So this is either, at some point the diaphragm, as Austin predicted, is sort of interacting with this syndrome whenever the patient takes a deep breath. And whether that initiates in the lung or the abdomen, we'll figure out further. But certainly the presence of the nausea and the vomiting and the early satiety points me more towards, below the diaphragm and sort of assessing that a little bit further. So, I think the pertinent negatives of the GU symptoms, I think that tells me it's probably less related to that. And I think the propensity of the nausea and vomiting, I guess I would love to characterize that more about like how severe this was. Was it just mild? Has the patient been unable to eat? How many times were they vomiting? What did the vomiting look like? And things of that nature, I think would be helpful potentially to say what's been going on. And I think what is um, interesting for me to try and figure out is if there's something intraluminal or extraluminal. And the more that I think about it as well is that the fact that there's a pleuritic component to the pain makes me think that it's probably more likely to be extraluminal unless whatever has happened inside the lumen has made its way outside and led to either peritonitis or sort of local mass effect of the area. But I think it's very peculiar. I think I'm quite concerned about the patient, not only with the how old that she is, but sort of the acuity of the syndrome and how pretty significantly progressive it has been in a short time on the background of inflammation. Um, So, we don't get any sense of hepatobiliary pathology, and the pain isn't sort of in the classic location for that. But I think the background here, otherwise, particularly the social history, will be very interesting. It sounds like we heard that the patient had any recent travel, no significant sick context, but I think a sexual history here will be very important. And then also, like a GU history otherwise, since the patient been pregnant before, and where they are in their menstrual cycle or things like that, I think also might be helpful. So I think, we're still using that arrow has Austin has recommended. I think we're probably below the diaphragm, and then just trying to specify further now that we where exactly we are. Nausea, vomiting, and early satiety themselves are not all that specific, but all of the combination together plus the syndrome definitely makes me think of something affecting, the GI tract, probably the upper GI tract. Um, and with the fact that the diaphragmatic irritation makes me think potentially it's more of like outside the lumen pushing into it. But could also be an inside out phenomenon as well. But also, I'd love to know how you're breaking down this information.
No, I think that was superb and agree. I think that we've gotten signal to an upper GI process, and whether the process that we're trying to solve is a direct thing wrong with the upper GI tract, or what we're trying to solve is that a sort of like side effect or consequence of, let's say, splenomegaly or some sort of inflammation related to the spleen. I think that that's an open question that we'll be looking to solve. And I agree. I'm sort of like anxiously awaiting the sexual history to understand that a bit more, because that could certainly become very relevant very quickly. I'm wondering how like we're going to get some more clarity on the inflammation a bit more about like what that actually means. It sounds like there's sort of like subjective fevers and chills, and whether or not it's something like to invest in heavily from like an infection standpoint, or just something that the patients experience more like from a catecholamine excess, then that'll be that's something that we'll have to explore before we sort of like dive really deep into the infectious malignancy, autoimmune drugs, and endocrinopathy mnemonic of IMAID for inflammation. Um, Going back to the beginning of like this idea of severity, I think, one way, like I have to say that I don't ever ask the patient like what their pain is on a pain level scale, because again, everyone's experience with pain is very different. So I don't find it to be very helpful. But what is very helpful is saying, hey, like, what can you do? What cannot you do now that you could do last week? Or what do you want to do that you cannot do because of the symptoms that you're experiencing? And if they're like, well, I can get through my day and do everything, then um, I feel slightly reassured that they're able to work through it. Now, some people are just able to really work through a lot, so you have to really tease it out. But I would say that's by far more useful and high yield question than asking like, is your pain a 10 out of 10? Is it 1 out of 10? Like, where is the scale? It's just not very useful clinically. So yeah, no, really brilliant discussion, Alec, and excited to learn more from you, Heman.
Yes, so with the amazing discussion with some question, can give you answer. So she has no OB/GYN problem, normal menstruation, no malignancy, no history of abortion. She had two children, and she didn't have any problem with that. And also, her I think the pain level really made her not to do well on the house chores and the living daily life well enough. So, but then her vital sign is not really abnormal. Her vital sign was stable for this patient when she came to the hospital, and generally alert in no acute distress. HENT is no scalar icterus cardiovascular wise, regular rate and rhythm, and no murmurs. Pulmonary, lungs clear to auscultation bilaterally, and abdomen, left upper quadrant fullness and tenderness to palpitation, and spleen palpable, no rebound or guarding, no hepatomegaly, extremity, no edema, cyanosis or clubbing, neurologic, alert, and oriented. I will stop here and maybe you can give us some more wisdom to share.
Yeah, wow, beautiful. Thank you so much, Himun. And yeah, I think we're learning that, the patient indeed does not have much of a history whatsoever, had no concerning GYN issues. So we're going to put that to the side for now. And then really, Human's been able to clarify that this is really greatly affecting this patient's quality of life and how they are able to do their day-to-day activities. So I think again, just speaks to the severity of their experience. And the exam, we are feeling some enlargement in the left upper quadrant and what we believe is a palpable spleen. For many of our listeners and people that are joining right now that do not practice in the United States, I 100% guarantee that your physical exam scores are exponentially better than mine. And so you can probably feel very confident about palpating a spleen. In my experience with it, I'm pretty poor, even when I know that the patient has an enlarged spleen from imaging. And then I've personally been in a situation where I thought someone had an enlarged spleen or an enlarged liver, and in fact, it represented other organs that were enlarged and not from there. So I think right now we can say that the person has an enlargement in their left upper quadrant suggestive of splenomegaly, but I'm not yet going to translate that with 100% confidence in my mind, and therefore not going to invest a whole lot diagnostically into that currently, except I'll say that, what, whenever you see a large spleen, you ask yourself, hey, what is the most common reason for that? And usually it is because you have extra water in the spleen. And then you have to ask yourself, why is there extra water in the spleen? And usually the most common cause of that is that because there's something wrong with the liver and that results in portal hypertension and then you get splenomegaly. But Heman has done a very nice exam and given us a very nice history to suggest that this patient really has no risk factors to develop liver disease and therefore portal hypertension. Now, can you develop portal hypertension without cirrhosis and liver disease? 100% you can. So we'll see if we arrive in that level of esoteria, including like needing to focus on like a clot in the splenic vein, for example, and then leading to like acute enlargement of the spleen and then capsular stretch, which would probably fit pretty well with this presentation. Um, but I don't really want to invest in that too much right now. I think what I would do in real life is because I have an ultrasound machine in my bag, I would just ultrasound the upper quadrant and take a look and see the spleen and see what it looks like if it's really terribly enlarged. If I see a lot of heterogeneity, before I would say like let's run to the CT scanner because I'd have to send the patient to the emergency room or try to arrange that rather expeditiously. But I agree with what Alec discussed earlier is that this patient is definitely going to need some additional evaluation to make progress as far as imaging goes, probably in the form of a CT scan. And then I guess I'll pass it to Alec. Like, what other things on physical exam that Heman hasn't mentioned for so far that you might look for to try to help you make progress diagnostically?
Yeah, I mean, excellent discussion, Austin. So I think anytime you feel like a spleen is big, and I go with Austin, my physical exam skills are poor to feel confident in the splenomegaly, although certainly the syndrome is like fairly evocative of it. So I think just for discussion purposes, I'll act like we're going to confirm the splenomegaly. So I think on exam, what I'd be looking for is lymphadenopathy would be something to consider, and then I'd be looking at the skin. Not only to assess for sort of arthralgias or arthritis, but also to see if there are rashes or if there's any evidence of petechiae or ecchymosis. And then for that reason, I would also be looking in the mouth. And the reason that is anytime I see splenomegaly, I'm pretty much always running to the CBC. Because of the most of the time, you're going to see something there that's going to help you, right? Like Austin said, the most common cause of splenomegaly is related to portal hypertension. So I think the fact if the platelets are normal would be somewhat interesting, or if the patient doesn't have leukopenia. And then if the patient has anemia or has pancytopenia, you might be thinking about bone marrow pathologies. Or, let's say the CBC is overall underwhelming, but the MCV is 60, right? Could the patient have undiagnosed sickle cell trait or thalassemia or something, right? That could be leading to splenomegaly. So I think I would be thinking about all those things in real time, and then also trying to do a good skin exam and look inside the mouth. If you find thrush or other signs that the patient might have an immunodeficiency, particularly HIV, that would be something that would definitely raise my attention. I think I'd also be doing a good pulmonary exam as well, just because with splenomegaly, its association with granulomatous diseases is well known, and just thinking about whether or not there could be a signal there. And yeah, I think otherwise, that's what I would sort of be thinking about. Other signs of activation of the reticular endothelial system, and then sort of any subtle signs of immunosuppression, or if there may be cytopenias that we pick up. So I think that's sort of what I'm thinking. If the splenomegaly is confirmed, as far as etiologies related to that, definitely would be thinking about primary hematologic problems, either sort of cancers or hemoglobinopathies or things of that nature. Infections, particularly like tick-related infections, some viruses, granulomatous infections, and then autoimmune disease like Still's being the main one. But you also think about lupus or Speltes in the appropriate situation. And there are certainly other things to think about, like, as well. But I don't think we have a great sense of the sort of extra left upper quadrant features that we're having. And I love your focus too to say, hey, like, we think it's a spleen, but I'm not confident. So let's actually confirm that. Be sure that she doesn't actually have like a massive ovarian tumor, right? Or that she doesn't have something even big in the tail of the pancreas, or they don't have a sarcoma, right? Or this isn't actually a lymph node conglomerate, right? And so I think the imaging is going to be critical here to better characterize the syndrome. And then I really think the labs, particularly the CBC, are going to be quite interesting. And then depending on what that shows, whether or not we need to consider, other sort of blood tests that we don't routinely send, but we may think about when the reticular endothelial system is activated, like an LDH and uric acid might be something to think about. But otherwise, HIV, every patient, every time, for me, and just because Austin and I, like, we always like never mention it early enough, so I just bring it up soon. But yeah, Austin, any additional thoughts before we get some more information from him?
No, that was superb. I think, yeah, the only thing I was asking myself was like, would I think to do like a thorough lymph node exam in real time with the patient? And I'm not sure. I would like to say that I would, because, again, as you said, like what signal to the reticular activating system that I can actually feel and detect with my hands. And I think it is a lymph node and glandular exam. So probably I would try to do that. But whether or not, if you think through some of the causes of splenomegaly that you alluded to, probably the lymph nodes are going to become enlarged or not something that you're going to feel with your hands. That being said, if you detect cervical or inguinal or axillary lymphadenopathy, that could be a really powerful clue as far as to why they would do that. Though I think the time course is a little bit long, a little bit short in this context for some of the things we're invoking. But yeah, all right, human, excited to learn more.
Yes, rich discussion, and I will answer some of your question. We did during the physical exam, there was no lymphadenopathy, and also no rashes and no oral thrush. And also, Sam, I were asking like sickle cell trait, thalassemia. So there was no sickle cell trait, and unfortunately, I should say fortunately, she didn't travel much. So I don't think that there'd be like any malaria or any problem or Lyme disease. She didn't have any recent travel or like tick bite or yeah. So those are could be the answer to your question. And also we definitely did a CBC and the liver function test and renal function test, even EKGs, so because we have to rule out, on like non-typical chest pain or like could be there. So EKG was done and everything was within normal limits. And we even did a stool exam because the patient was having some diarrhea. So, but the no parasite ova, viral marker HIV, HBV, HCV, TB were all negative. Chest X-ray was normal. So, what would you like to do next? And any lab, if you are wondering about any lab value, please let me know. I will answer to you.
Okay, thanks so much, Hemo. So just to clarify, the CBC was completely normal. There was no leukocytosis, the differential was normal, there was no anemia, there was no thrombocytopenia, it was completely normal. Okay, wow, very interesting. So I think we, the HIV is ruled out. The viral hepatitis, which is a great thing to think about, that can cause sort of splenomegaly in theory as well. Is all completely unrevealing. But I think, here, I think just to be sure that we're confident with the problem that we're trying to solve, most likely being splenomegaly, imaging here to confirm is going to be exceedingly important. So here, I'm a little bit hesitant to dive in deep into other things until we better define that. So I think a CT abdomen pelvis with contrast is going to be very important here, not only to assess the spleen, the surrounding structures, but then like is there lymphadenopathy or not? Are there like sneaky bony lesions that she doesn't have symptoms of? Is there fat stranding around the pancreas? Is there something else that we could be missing? We're not getting a sense that there's a thoracic component of disease, like based off symptoms, and then the negative chest X-ray. Although the chest X-rays, as you know, lots of people have discussed on VMR are imperfect. But yeah, sort of reconciling what could cause a normal CBC plus splenomegaly, if we can confirm that, is very interesting. And so I guess just because the CBC is normal now with the acute syndrome doesn't mean it will be normal later. So I think trending that will be important. And then you're really assessing for other subtle things on the CBC, like is there mild lymphopenia? Is there lymphocytosis? What are the neutrophils doing? I think will be quite helpful. And then, we're not getting a clear sense of we're getting some inflammation from the history, but less so from the exam. But monitoring the patient's temperature and things like that, I think are and other vital signs would be very helpful to make progress. But I think from here, I'm going to struggle without imaging, just because like a spleen being big versus a spleen that looks necrotic versus a spleen that's the size of the splenomegaly, right? Is the spleen like 20 centimeters, or is it just like 10 or 11? It's just like very mildly elevated. I think that would make a difference. But I think, the normal CBC in the setting of an acuity, if this was related to an infection, I would have expected to see something, maybe some leukopenia, maybe some leukocytosis, maybe some thrombocytopenia related to the platelets, thrombocytopenia related to the viruses. And sometimes there are certain malignancies that can isolate themselves to the spleen. Like there's like primary splenic lymphoma, and there's like low grade lymphomas. Like I'm blanking on the name of them, but they can like just present with isolated splenomegaly. And there are other rare things, but I think a lot of the systemic syndromes that present with splenomegaly, we're getting less signal for. But I think the imaging here is going to be really helpful because the patient may be so focused on their the current systems that they're not really saying, oh, now that you mentioned, I have had a cough, like because the pain is so significant, or maybe I have had some joint pains. um, so I think it's just really going to need the imaging to make further progress. But with the fact that you can feel it on the exam, plus it's causing seemingly compression of the GI tract, whatever is going on there shouldn't be subtle. Like we should be able to see it, and then we can make further progress from there about like what is the systemic nature of this disease, or is it purely isolated to the spleen? Um, and then non-inflammatory splenomegaly, we could later talk about it in case she had some like undiagnosed genetic thing or something else. But yeah, I think I'm a little bit lost without the imaging, Austin, but I'd love to know what you're thinking.
No, I'm right there with you. I think what struck me was again like basically like almost like isolated splenomegaly to your point. Like there's not really too hectic of a picture outside of that. There's not any signal that we've come up with the lab. So it suggests that maybe there's something wrong just in the spleen. So I think that'd be a useful piece of information to try to tag along to. Probably would get the LDH if we haven't already, just to have it. I agree with the idea of a lymphoma. I think the other thing is like what could isolate and be relatively less hectic, and it's maybe like the draining system or the plumbing of the spleen. And so probably we'd go back to investigate that hypothesis, though, like why someone would get like a splenic plumbing issue like usually implies that there's some sort of other inflammatory thing at play that we might get signaled to. So it's a little bit tricky. I think the other thing I was trying to reflect on is like, is the CBC like where normal is abnormal? Like maybe the person at the beginning like had some cytopenias and then developed some acute complication and then developed like a relative leukocytosis, like relative to what it was before. And so it's coming out as normal. But actually, if we went back and had the luxury of like having prior CPCs, maybe we would see signal to that. But that's so like nebulous. I don't think that would lead to too much progress. And I agree, like really the way to understand this condition is to get imaging of the spleen. So that's what I'd want. Tell us what happened, Himun.
Yeah. I will give you the image. Sono spleen 14 centimeter with a solitary and echoic cyst 9.7 times 8.7 times 7.9 centimeter, smooth 0.4 centimeter wall, no septation or calcification. We did a CT abdomen, single cyst 9.8 times 7.8 centimeter, and no calcification and solid part. And splenomegaly was 14.7 centimeter. And yeah, and I forgot to you asked me one value and I forgot to give you answer. If you can ask me again, I will give you one. And then
Oh,
there's some yeah.
yeah, I think I asked for the LDH, but it seems
LDHE
maybe less
was not
relevant.
yeah, not
Yeah. Mhm.
significant. Yeah. But if you wanna know another value, I will give you.
No, that's all I got. Was there anything else that you wanted for this aliquot, or is this the main thing?
For
Sorry.
Alec and yeah, I think Alec asked me and I think I forgot to mention
Oh,
that.
no worries. Yeah, no, no. I think
Yeah.
we can try to discuss this here if that's okay. I think yeah. So I think, as Alec mentioned, we need to try to understand the problem, and we've grounded ourselves in a problem with the spleen. So not only is the spleen seemingly a little bit large, it also has a very large cystic structure in it. So 9 by 7 centimeters, which is humongous. That's like the size of most people's spleen. Especially like smaller women. So what can cause a cyst? And I think this is where I'll have to really stretch my knowledge because I have no familiarity with splenic cysts. In fact, I've never seen one in my entire life. So I'll just have to borrow from other organs that have cysts. And I think the one that I probably see most commonly is the kidney. So what's the most common cause of cysts like in the kidney? Usually it's just sort of like degenerative change in how the tubules form, and then they just fill up with urine essentially, and that's how they kind of grow over time. And Hemun has given us a lot of really nice characteristics of like there's no septations, there's no calcifications, there's no thick walls. So the likelihood of this being malignant in origin is relatively low. So I think that's one possibility. But if you are kind of thinking through the causes of cysts, almost all renal cysts are asymptomatic. And so I'd imagine that most splenic cysts are also asymptomatic as well. So why would someone become symptomatic? So one is like it just so happens that the cyst sits right next to the capsule, and then as it starts to grow, it causes stretch and then causes symptoms. So that could be the case. But I think given the size of this, most likely I think this is relatively acute in onset. And so I think that's an interesting thread to pull on. So one thing to think through is like what can happen quickly and be severe and cause stretch is bleeding. And so we'd wonder about a contained bleed within the spleen. But usually blood would not look this way, especially as time has passed with their symptoms. So that seems to be a little bit less likely. Um, the other would be like some communication that would form within the like something that like some sort of GI connection to like drain fluid into the spleen. But again, now I'd expect that to be a lot more inflammatory. We'd probably have some sort of prior picture or history of surgery to suggest like a risk factor for that. And I think that it would be unlikely to be sort of like simple fluid to manifest in that way. I suppose maybe if there's like a vascular malformation that is started to drain in that way, like maybe it could show up as just sort of plain blood. But I'm getting the idea that this might just be sort of like a general cyst. I think the other thing that can cause cysts is, we've described why malignancy is probably less likely, would be sort of infectious. Like I think about like echinococcus, for example, but I don't usually that it doesn't have this sort of simplistic characteristic. Um, the other phenomenon I'm sort of thinking from kirtan is like maybe this was pre-existing and then there's a complication that happened within it. Like it became secondarily infected, there was a bleed, something like that. Um, or it sort of had a way to spontaneously drain and that drainage pathway got blocked, like sort of thinking of kind of like a gallbladder that gets distended. Um, but I have literally zero illness script for the splenic cysts, so I don't know, Alec. Maybe you've had experience with this, so you can provide some more meaningful insight.
No, also I think that was a masterclass on how to break down a problem even if you don't have experience with it. And I have never seen this one exist. I think something that strikes me about the image is about how like sort of well circumscribed it is, and how thin the wall is. And yeah, so I think, could this have been congenital, and then just grew to a point where it became symptomatic? I guess in theory that would be possible. But like 1 week of symptoms is a little bit strange for that. I imagine she would have had some clue, right? Related to this. And then, the vascular hypothesis, I think, is an excellent one. I guess if it was hematoma over a week, I guess I imagine there would have been maybe some calcification. And then also, like, did she have some preceding trauma or something else? Or, did she have just some sort of like non-specific viral illness, had splenomegaly, then it bled, right? But again, the sort of like circumferentialness of it is just like, I don't know, a little bit, it's so large and seems so strange. Um, and then yeah, like typically when I've seen like splenic lymphomas or other like masses in the spleen, they're less they're more thick and they're sort of less well circumscribed. So I think it looks a little bit less consistent with that. And I think echinococcus is one definitely something to think about. So I'd love to know the patient exposures, like what they do they have any pets, are they from the United States or not? If they have anything in the liver or like anything in the lung, potentially, for signs that otherwise. And then is there any eosinophilia or not, even if it's mild? But then I think for those, like I don't know, I've never seen it to know, like is there supposed to be septations or not, or what exactly is going on. It may depend on the stage, but I'm not exactly certain. Um, and then something else that you could think about too would just be, you know, I guess in theory, could this be a neoplastic and sort of the characteristics of the wall like it are different, and we only have one cut, so it's hard to know how it looks through the rest of it. But if it's that simple, I'm not really certain. So I think in this instance, like as Reza says, I would just go to ChatGPT and look it up or open evidence, and then I'd be asking the radiologist like, what do you think about this? What would you prioritize? And then sort of deciding from there, like who's going to help us to figure this out. Um, because sometimes like if it is a echinococcus, biopsying it can lead to other problems, and so you have to rely some on serologic tests and just empiric treatment. So I think at this point I'd be calling my radiologist. I'd be doing some research on my own about what this could be, because so far in the imaging, like it continues to be an isolated splenic syndrome, but it's splenomegaly plus a splenic cyst, and sort of I would be having to look that up in real time. And then I definitely would be sort of interrogating the CBC a little bit more, interrogating their exposures and like past medical history, and then deciding like from there, are we going to get a blood test to figure this out, or are we going to have to call our, interventional radiology doctors to sample this? So yeah, Heman, I'd love to hear more.
Yeah, I was a little bit reluctant to give you the uh, differential count. So like I'll give you the differential count for. So this patient had the eosinophilia. It was just a moment. Yeah, eosinophilia 10.9%. The reference is 1.6% is normal. And then the patient is very shy, so she was not really like giving all the history. She later mentioned that she worked on a farm in India 7 years before coming to the United States. So those can give you a little bit more clue. And before I give you the old answer, I will want you to discuss a little bit more.
Okay. Austin, is it your turn or mine? I blanked.
I think it's your turn.
Okay. Yeah, thanks so much, Heman. So I guess, and just to clarify, so the eosinophil percentage was 10.9%. What was the total white count, or do you have the absolute eosinophil count? Or?
Oh, I don't have an absolute eosinophilia count, but it's a eosinophilia. So, yeah, I don't have that specific absolute eosinophil count. I'm sorry about that.
No, no problem at all. So like, if we just say that, hey, maybe the patient had a white count of like eight per se, that would be like an AEC of 800, which is quite, anything over 500 is what you would typically count as elevated. So I think the combination of eosinophilia plus a splenic cyst plus the exposure history would definitely make me think about a parasite. And the one that I think about primarily causing cystic lesions that go to the spleen would be echinococcus. But I'm sure there's other ones that can do it too. I just don't have the familiarity with parasites to know which ones are which, so I would be looking that up. I have to, I honestly don't know. Echinococcus is the one that I think about causing these like really thin cystic lesions like this, Austin. But um, yeah, I think beyond that, I'm not really sure. I have a lot of other unique thoughts there, but I would love to hear what you're thinking.
No, I think I don't have anything else that I'm thinking. Yeah, I mean, I only have echinococcus in my mind. Again, like I just don't have enough familiarity with it to understand like as you mentioned, like, wow, this looks like so pristine. Like if you look at a bunch of CT scans over the years, you'll see renal cysts that look like this over and over and over again, and they never really look too exciting. And so, as you said, maybe if we had other views and other cuts, we could really scroll through, review with the radiologist to say, is there anything unique about the wall or the structure or anything would be interesting. And then I guess to your point, we're sort of saying like splenomegaly and cyst, but I wonder if it's just that this cyst has become so large that it's caused capsular stretch to say that it's splenomegaly, but it's not that there's any sort of actual issue in the splenic parenchyma itself outside of the cyst. And so therefore, like splenomegaly is actually the wrong frame to solve, right? It's just like splenic cyst that's causing splenic enlargement. Does that make sense? Maybe that makes sense to my mind. I don't know if that makes sense to other people, but that's how I probably wouldn't actually think too much about splenomegaly. I would just say, hey, I need to solve this cyst because it's super big. As we mentioned, it's like almost the size of some people's spleens. So I agree heavily that I would probably rely on that. The other thing is like an absolute eosinophil count of around 800, as you said. Like today, I saw a patient in clinic earlier that like had an absolute eosinophil count of like 1200 or 1500, and they've had it for like you know, 6 months. And it's like, is it relevant? Is it not relevant? Like, there's so many things that can go into eosinophilia. The only thing that makes it for us want to be making it signals like the person's background and the fact that there's like no medications, no chronic illnesses, like no, haven't heard about allergic symptoms, like not taking vitamin supplements, like we haven't heard any other signal to suggest otherwise. And so I agree that we should incorporate it into our problem representation for now. But eosinophilia as a base rate is like so 80% of eosinophilia or more is like just medications, A to P. Um, and so it's like usually not like terribly fruitful to solve. But so I'm open to the possibility that it's like might not be relevant in this case, but I think because it's a clinical reasoning exercise and because we have this background, like we definitely want to incorporate it into our problem representation, but I'm open to it being sort of noise rather than signal. But yeah, Moon, tell us more.
Yeah, to diagnose this hydatitis, echinocosis, we need a clinical epidemiology clue. Like she's from India and she worked in the farm, maybe exposed to sheep, cattle, like dogs, and also imaging is most important. So ultrasound is like shows like a CE1 is active, like unilocular, and the CE2 is multiceptor. So it goes to until like CE5, like multiple classification. And then we do like ELISA, IgG, Echinococcus. So we did that, and the result was IgG was 1.07. The less than zero point 0.9 is normal range, and IgE was 593.4, which is the normal range is less than 100. It confirmed the hydatid disease. So treatment was a total splenectomy and abdominal wash with a 3.3% NaCl and metronidazole. Actually, the albendazole should be ordered early, but it really took a long time. To order albendazole, it really like takes like 4 weeks. So it's better to like order early. So if you can give albendazole before the surgery, it will be really good for this patient. Albendazole was not ready before the surgery. So yeah, if you want to share more, I'll be grateful.
Whoa, yeah, no, thanks very much, Moon. And yeah, I think it speaks to um I can't recall ever ordering albendazole in the hospital, but I'm surprised that it took quite that long. But I can certainly believe that it's not something that we like stock readily around compared to other places in the world. And unfortunately for this patient, like they had to have their spleen removed, but simultaneously that was a way to like keep everything contained and to remove, and you can live without your spleen. So in that sense, I'm glad that the patient did well and can go on with their life. But yeah, really humbling case. I mean, I think as Alex had predicted, like this isn't a new thing. The patient hasn't been living in India for a while, and then all sort of chronic diseases can present acutely, and so they just so happen that either it grew to the point that it would cause symptoms, or something activated it, and then it grew, and it really affected the time course. But really, if you go back and take a rich history, as Hee-Moon did, then like you'll find the susceptibility from years ago. And I think that's a really humbling part of the case. And then the other aspect of like whenever you see organ enlargement, I think our automatic train of thought is like there's something with within the parenchyma that's growing, but be open to the possibility that there is like a extra parenchymal disease within the organ that is expanding the organ. And I think that was something that I had never reflected on before. So yeah, Heman, thank you so much for the case. Alec, what are your reflections?
Yeah, thanks so much, Eva, for putting this together. What an interesting case. I've never seen a echinococcus, and like in the times I've seen it, I've thought more about like liver and lung cysts. So spleen is something that's new, but um, yeah, I mean, I think the albendazole thing is interesting. I think it's just sort of where you practice. Actually, where I practice, we take care of a large proportion of people that aren't from the United States, so we have albendazole actually. So, like we see neurocystic psychosis and other things, and so, I guess I would be interested to know, was the cyst so large that regardless of the treatment, uh, wasn't going to get much better anyways. And I guess from my understanding, like a lot of times, like you treat the cysts, like with the albendazole to sort of kill the parasite, but like the cysts themselves don't get all that much better. So if they have local compressive consequences, then you do have to treat that. So I'm glad the acuity is interesting. I wonder if the patient like what exactly brought them into care, like they just get big enough to cause disruption, or um, did it more rapidly grow for some reason, or did something else happen that triggered them to come in? Because this didn't start 7 days ago. So I think that's certainly interesting in itself. But glad the patient is doing well. Hopefully, before they got the spleen out, they were able to get their vaccines, and they'll be able to stay on top of that. And yeah, just a lot of learning to be had from the case. And I'd love to hear your reflections and what you learned, Hima.
Yeah, so the actually the CE1 sometimes they don't require surgery, but this patient's symptom was really progressive and severe, and we were not getting any albendazole on time, so surgery was necessary. And also, even having albendazole, she had some side effect from the albendazole, like GI. Nausea and vomiting. So we had to change to mebendazole, and mebendazole ordering requires a lot of time too. So patient was not having a happy time. So I think those are the things that I learned, like always ask for the past medical history, like where she was and where was exposure. And yeah, so those are the very interesting things that, and also older albendazole as soon as possible. And yeah, those are things that like when you like see the patient and you learn every day, like how, to give comfort and everything to fit for the patient. So I think that's the one thing that I learn every day from my attending. Thank you so much for a wonderful discussion, Austin, Alec.
Thanks so much, Hemoon. Really appreciate the
Thanks.
case. Excellent learning. And yeah, thanks to Magnus for doing the scribing. And Austin, if any final reflections, otherwise we can pass it to Sarah for the teaching points.
No, let's hear Sarah's excellent teaching points.
All right. So on this case, we started by using an anatomic approach, considering both organs topographically as well as the layers you pass through in each quadrant to figure out what's going on in abdominal pain. The left upper quadrant can also include the diaphragm, the lungs, and the pleura. And radiation to the back can indicate a peritoneal component. We also talked about the fact that severe pain does not necessarily mean acute pain. And rather than asking about pain on a scale, it can be helpful to ask about limitations to normal ADLs to figure out a metric of severity. Systemic symptoms can be helpful for identifying whether autoimmune, infectious, or malignant processes are involved. We talked specifically about lymphoma. A trend in CBC can be more helpful than a single CBC at one time point, and the differential can point towards malignancy, parasites, bacterial, or viral origin. Evaluation of the spleen can require cross-sectional imaging, both due to limitations of the physical exam and to rule out conditions requiring intervention. Potential findings could include fat stranding, masses, malignancies, cysts, infarctions, and splenic vasculature abnormalities. Radiology could be helpful in deciding who to consult next after an abnormal imaging result. And then if a patient presents with left upper quadrant fullness and tenderness, we should assess for rashes, lymph nodes, and look inside of the mouth. And often the CBC can be revealing of the primary cause. For example, undiagnosed thalassemias. And then granulomatous diseases and HIV were also on the differential for this particular case, as well as other conditions that result in activation of the reticuloendothelial system. And then benign growths can cause pain by irritation of surrounding structures, such as splenic or liver capsule or mass effect. We also talked about blood or secondary infections of benign growths causing irritation that could result in pain. Another potential cause of pain in a benign growth could be formation of fistulization between like the GI tract or another place that would result in inflammation, resulting in pain. And then in this case, the spleen parenchyma was not necessarily enlarged, but the cyst itself resulted in a physical exam finding pertinent for splenomegaly. So yeah.
Amazing work, and making us sound so smart by saying topographically and all this nice synthesis of information. So I appreciate you making us shine. Thanks so much. Well, thanks again to everyone for another session, and we'll see you again next time. Bye-bye.